Absolutely. Anybody else have any questions?
I'm not sure if you made a crash course for OBG yet, but I was wondering if you had any tips for like questions about abnormal bleeding or stuff like that.
All right, here we go.
Oh, nice.
Let's see, we got not just a little bit, we have 24 pages here.
Dang.
All right, I'll type in abnormal uterine bleeding and we'll just go through some of the stuff here. So if it's abnormal uterine bleeding, the patient is older than 45, you want to get an endometrial biopsy. High risk that they have a cancer at that age range. And so if the biopsy doesn't show anything, then you can do a DNC at that point.
Mhm.
We're just going to fire through these here. I'll send you this guide. It's not completely 100% published yet,
Mhm.
but it's got a lot of really good stuff for you. Let's see. Let's start at the top. Oh, this is actually what I was looking for. So here's the abnormal uterine bleeding scenarios. So if you have bleeding plus a positive beta HCG with an intrauterine pregnancy and a closed cervical os, that's a threatened abortion. Got to make sure that you know that. These are some of these are going to be emergency situations, and some of these are very chronic. So, for example, F down here is bleeding plus weight gain, constipation, and fatigue. That's usually going to be hypothyroid or PCOS. So you have to use the whole clinical scenario. If they say the patient is pregnant and they're bleeding, obviously that's something that's a lot more concerning than somebody that's slowly gaining weight and constipated and bleeding.
Mhm.
The bleeding plus bitemporal hemianopsia. You guys have heard that before. That's prolactinoma. So you want to get an MRI of the brain, see what's going on. And then treatment is dopamine agonist like cabergoline or something like that. Abnormal bleeding starting with menarche. So usually it's because of anovulatory cycles. It's literally they're just developing. They haven't got their menstrual cycle down to an exact 28-day science yet. And it's from an immature hypothalamic pituitary axis. But if it's heavy bleeding or they make it sound like the patient is bleeding for a lot longer than you'd expect, let's say that they're like, every month the patient bleeds for 2 weeks, for example, and it seems like it's getting worse and worse over time, then that may be a coagulopathy, such as von Willebrand disease or factor V Leiden. If there's bleeding in menopause, you want to assume cancer in a question stem until proven otherwise. So you can get an endometrial biopsy, like I just was saying a little bit ago, especially if they're over 45, they're going to be getting closer to menopause. So you want to fire away with an endometrial biopsy. If they have bleeding plus severe menstrual pain, the pain here is really, really key. You want to start thinking endometriosis or adenomyosis. If they mention that it's like a boggy, uniform shaped uterus, then you're going to go with adenomyosis. But if it's like a nodular uterus that you feel in your exam or that you see on imaging, then you're thinking endometriosis. There's bleeding plus weight gain, constipation, fatigue. We said it was hypothyroid or PCOS. If it's a positive beta HCG with your bleeding, pelvic pain, but there's no fetus in the uterus, or they might say that there's an adnexal mass, that's going to show you that it's an ectopic pregnancy. You have to know this. You almost guarantee get a question on it. And so as you see here, ectopic will be a pelvic ultrasound showing an adnexal mass. And they can also give you a clue that there's a thin endometrial stripe. And that just basically means that the uterus doesn't have any proliferation or any growth. And so for the ectopic pregnancy, the treatment is going to be methotrexate. But if there's a contraindication to methotrexate, such as liver, kidney, immunodeficiency, peptic ulcer disease, pulmonary dysfunction, or an ectopic rupture, then you do a laparoscopic salpingectomy instead. That is more of a step 3 question. They're not going to push you much past methotrexate on step 2. Yes, it's possible they can ask you it, but they'll try and make it very obvious. They'll say something like there's free fluid in the posterior cul-de-sac, so you pretty much assume that it's a ruptured ectopic at that point. If the patient has fetal cardiac activity or super high beta HCG, like 1/5,000, then most of the time it's just better to go straight to salpingectomy. Methotrexate's not really as effective in these circumstances. So if you see ectopic pregnancy, generally you're going to go with methotrexate. The patient's got trouble with their kidney, liver, lungs, GI, peptic ulcer disease, immunodeficient, you're going to go with a laparoscopic salpingectomy. Obviously, you can have a bump in your LFTs with methotrexate. Your creatinine can take a hit. If they're immunodeficient, you don't want to just give them more of an immunosuppression medication like methotrexate. Puts you at high risk for peptic ulcers, all kinds of stuff. So if any of those are the case, you do laparoscopic salpingectomy. But the real key here is if it's ruptured, then you're definitely going to want to go to surgery instead. And this is kind of a step 2 or a shelf type question. If the patient is hemodynamically unstable and you suspect a ectopic pregnancy based upon the adnexal mass with a positive beta HCG, then you're going to just skip the imaging and go straight for the emergency laparoscopy, right? Pretty much any time in a question stem, they give you very low blood pressure with a very high heart rate, you're going to want to go to surgery rather than kind of muck around with imaging. And then last one here is most common cause of regular heavy menstrual bleeding in a non-pregnant premenopausal woman is going to be a uterine fibroid. And they'll list that oftentimes as endometrial leiomyoma in the question stem. It's just another word for it. Does that answer your question about bleeding?
Oh, yeah, definitely.
Awesome.
Thanks for sharing that.
Yeah.
But I just wanted to quickly ask because I saw prolactinoma. I
Yes.
always get that confused with pituitary adenoma. Which one is surgical removal?
Pituitary adenoma versus what?
Prolactinoma
Well, what is a prolactinoma? Where is it at?
in the hypothalamus?
No, it's the same thing. It is a pituitary adenoma.
Oh, right. Okay, yeah. Sorry.
No, you're good. So, good question.
Thanks.
All right. Anybody else have any questions? We're closing up here on exactly an hour. So if nobody has any other questions, then we'll just call it a day.
Thank you
Awesome.
so much.
Yeah, absolutely. Thank you guys for coming. Hopefully that was helpful. As always, let me know if you have any questions. We're going to do another session, I think, same time next week. Check the calendar just to be sure. Double check me on that one. But great to see you guys. Thank you all for coming. Thank you for the good questions. And if you need anything, just let me know.
Thanks.